is probably going to mostly be a review, but I just want to add a couple points to it if I can. So I'm going to start off with a case. So this is a 32-year-old male presents to ED because of drowsiness, fever, cough, diffuse abdominal pain, and vomiting. And on review system, we also found out that he has a fever and cough that started 2 days ago, and he hasn't been eating or drinking well. And presenting here is vitals, blood pressure is 100/70, heart rate 104, breath rate 24, temperature 102.2, and finger stick of 450. So before I go into the details, I'm just going to go a little bit over what I'm going to talk about. So I'm going to start with the pathophysiology of DKA, and then I'm going to a little bit about the presentation, the symptoms, the signs, the labs, DKA, and then move on to initial management, eventual conversion therapy, and then I'm going to talk briefly about the root causes of some of the presentation of DKA. So pathophysiology. So this is just a very simplified version of pathophys. I didn't want to go into too much in details because a lot of chemical names, no one ever going to remember when we were using in the ER. So usually start with the initial insult, whether it's an infection or whatever. This leads to insulin resistance or deficiency. And from there, I kind of move on two pathways. First of all, it's going to increase the blood sugar because of decrease in the insulin resistance. Increase in insulin resistance deficiency. At the same time, it also causes peripheral, like lipolysis from the peripheral fat, increased fat production. It leads to increased amount of fatty acids and lead to increased fatty acid uptake by the hepatocytes. While these fatty acids are in the hepatocytes, most of them are converted to acetyl-CoA. Usually, acetyl-CoA going to enter the Krebs cycle to produce energy, but when you have increased amount of acetyl-CoA in the body, especially in the hepatocytes, these eventually becomes ketoacids because the pathways become oversaturated. These ketoacids eventually form ketones and are released into the blood. So for patients coming in with DKA, usually these are pretty rapid onset, happening within 24 hours. They come in with polyuria, polydipsia. Some of them always also have abdominal pain, nausea, and vomiting. Some of the things you might notice on physical exam are tachypnea, tachycardia. You might also notice very dry mucous membrane. And depending on the patients and how sick they are, they can probably sometimes notice altered mental status. So usually, how altered they can also give you an idea of the level of DKA they're in. For example, when patients are usually on very mild DKA or moderate DKA, they can be pretty alert, but then slowly move on to drowsy. And when they're in severe DKA, they can present in comas. In terms of blood works, some of the things you see are, the first thing you usually see is the elevated blood sugar from the finger stick. But further investigation will reveal serum ketones. Sometimes you also see urine ketones, if you send the urines. But the one most important thing is the anion gap acidosis, as well as the different electrolyte abnormality. The most common one and the most important one is probably the potassium, the hypokalemia. Here's just a brief breakdown of the different lab values you will see in DKA. So for a mild DKA, usually you see a slight acidosis, 7.25 to 7.3. The certain bicarb is a little decreased, but it's not significant, and the anion gap is usually pretty small. As you move on, you can become more and more acidotic. The bicarb can dip down further and further, and eventually in severe DKA, you have pH less than 7, with bicarb less than 10, and a gap greater than 12. I've seen going to 20s and 30s and maybe 40s. So the first management of DKA is a lot of patients sometimes when they come in, especially when you have underlying cause and cause them to be in shock. You want to start with bolusing fluids. Usually we do exactly what we do most time when patient is in shock. We do 15 to 20 cc per kg per hour. However, if not in shock, you can start with just fluid replenishment of 250 to 500 cc per hour, depending on patient's weight and size and how dehydrated they are. Usually the fluid choice are normal saline, half normal saline, or lactated winner. So when it comes to fluid choice, usually we kind of jump straight into normal saline because it works well. It's one of the fluids we use most commonly. However, when we in these DKA patients, when we give a lot of fluid, one of the things we have to be aware of is hyperchloremia. Studies have shown that hyperchloremia is associated with all hospital-caused mortality. One of the most recent papers I found was associated hyperchloremia with hospital mortality in critical ill and infected patients. In this paper, they measured basically the level of chloride in the body when the patient first come into the ICU, and 72 hours later, what they found that at 72 hours, not when they first came in hypochloremia is independently associated with hospital mortality, with odds ratio of 1.27. And for those patients who come in initially with hypochloremia, every increment of 5 in the chloride level is also increasing mortality with odds ratio 1.37. So the point here is that we can start with normal saline, but if when we do DKA patients, we check a lot of labs. Some of the things that we should be watching out is the chloride level, and once the chloride level starts going up, we can start switching to lactate, which is not chloride, which prevents hypochloremia from forming. Another key concept in managing DKA is to keep an eye on the potassium level. So hypochloremia is associated with a lot of mortality, especially in cardiac. It can cause different arrhythmias. So if a patient comes in initially with DKA and the K is less than 2.3, it's important to first hold insulin and give them 20 to 40 milligrams of K per hour until their potassium goes above 5.3. If the potassium is between 3.3 and 5.3, you can start insulin, but just always give about 20 to 30 milligrams of potassium in each liter of fluid you give them. The goal here is to maintain serum potassium 4.5 throughout the treatment of the DKA. In terms of insulin therapy, when a patient comes in DKA with a gap, we want to start IV insulin for them. So there's two choices on what you can do. The first one is you bolus them with 0.1 unit per kilogram, followed by a continuous infusion of 0.1 unit per kilogram per hour. Alternatively, you can increase the dosage a little bit for the infusion rate and avoid a bolus by giving 0.14 unit per kilogram. So there's an endpoint to all of this DKA. Sometimes we don't see this because they just got bumped up to the ICU, but a lot of times, ICU is full, or the patient is in pretty mild DKA, which is managed in CCT, so we do come to a point of transition. Imagine these DKA patients, usually we do Q1 or Q2 finger sticks, usually Q1 in the Q settings. When the finger sticks drop below 200, you can start adding dextrose to prevent a hypoglycemia from the insulin infusion. You don't want to stop the insulin infusion until the gap is closed. You can decrease, but you don't want to stop the IV insulin infusion. Once the gap is closed, you can start considering starting the patient on basically their subcutaneous heparin. If a patient came in with prior insulin regimen, you can start them back on their insulin regimen. However, if they're new diabetic or they just doesn't know their actual home insulin, you can start their basal and bolus based on their weight. So what you can do is, so you can calculate their daily needs for insulin. It's usually 0.5 unit per kilogram, and you can split that to 50% basal and 50% bolus. Usually the basal is the Gargine, and then Lantus, and then you can do TID or before every meal, the bolus, which is usually aspirin here. And when you're treating these DKA patients, you all have to remember that there's underlying cause to these DKA. The actual acidosis doesn't really happen without a cause. Sometimes, it's just patient have a decreased intake because they're having a gastroenteritis, so they haven't been taking the insulin. However, a lot of these cases, there's a major illness going on. For example, if there is a major infection or is the MI, or even a stroke can cause them to have acutely elevated resistance to insulin, DKA. At the same time, a couple of small things to watch out for is there, for example, a lot of type 1 diabetes, they have these pumps, and they're saying they are not being safe, they've been taking insulin all the time. It's just whether they're just a malfunction of the device. And and being in Kings County, we see a lot of patients who have just psychosocial issues, whether they're just not compliant because underlying psychological issues, or they just can get insurance, can get their medication. So these oftentimes will ask us, maybe get the social worker involved and help them fix the underlying cause, so they don't come in here every other day with DKA. And you have my references? And thank you.
That was awesome. I have a question. Do you usually keep the drip on and while you're bridging, when you give the long acting, do you keep the drip on for a certain time, or is it you stop the drip and give the long acting?
Once I give the long acting, the drip should be off.
No.
Leave it on?
Keep it on.
Even if the gap's closed?
Keep it on.
Yeah. Keep it on.
2 hours. Okay.
Thanks for clarifying that.
I wasn't sure either. That's what I was asking.
So even if the gap is closed, you give long acting.
It takes time.
But put long acting to work. Any other questions?
Yeah. So you keep the drip on for 2 hours after you give the bridge? Correct.
Correct. I don't think it's standard. It's kind of a practice. It's kind of a practice. Different practice. CGC knows their intensiveness.
Usually we want to have a bridge of some sort. You stop the insulin and then you give your sub-Q or your IM, sub-Q ideally. Then the insulin drip will stop and then you won't have any insulin on because the sub-Q takes time to be absorbed.
Would you change the rate of your drip when you're bridging them?
I usually do an hour.
I thought we hear anything else?
Dr. G?
A couple things. There's more than one way to skin a cat, but they're different. As long as you know the principles and know how to adjust it, and you're checking on the patient, you get away with a lot of different things. But you just have to be very conscientious. Yeah, if you're going to stop, if you want to stop your drip, then maybe you can put the nurses at that point. You're getting a long acting, then you got to watch your short actings as well, and make sure they don't go back into it. So, but there are different ways. These aren't strict guidelines. I've seen them treated different ways. For example, one of the things I do is once they're well hydrated, and I've calculated my sodium, with the glucose thing that changes it, and I see now they're good to have good sodium and they're good volume. I actually don't switch to lactated ringers. I switch to half normal, but because they usually at that point need more free water than they need salt, or especially than they need chloride. So I switch to half normal plus potassium. And then, once their sugar gets down around, below 300, below 250, and then I'll hang my D5 half normal or D5 and a third with potassium and cut my drip in half, as long as they're still ketotic. But again, there are a lot of ways to do this if you know the principles. You just have to be very conscientious and watch these patients like a hawk while you're treating the underlying cause, which is very important.
Any other questions, comments? All right, thank you.